Yes, thank you, Dr. Verenda, for inviting me to speak in this section today and for being part of this great course. So we are going to talk today about post-laser vision correction IOL calculations. I probably do several of these calculations a week now with our patient population. These are my financial disclosures, which are not relevant to today's talk, but we have about 20 years of laser vision correction, and even here in India I've talked to several doctors who were early pioneers in laser vision correction, so we're starting to see more of these post-refractive and post-PRK patients entering the cataract market. And obviously it's increasingly important to have accurate methods of IOL calculation, and we've heard a little bit about that from Dr. Manisha this morning. And as pointed out, lens calculations have really improved over the past several years. We have optical biometry now, we have more accurate keratometric readings, personalized IOL constants as well, and more advanced formulas, but really the calculations for post-refractive patients are definitely more difficult and less precise. As pointed out, we are all familiar with the SRK formula, and historically axial length has been the principal reason for errors, but really with post-laser vision correction patients, keratometry has really become the most critical factor influencing IOL accuracy, followed by effective lens position, which I'll touch on a little bit later. Although our theoretical formulas are good, they're very old, and they do not work very well for post-refractive patients. And why don't they work well? Well, obviously, the keratometers and topography devices really only measure the anterior surface of the paracentral cornea, and these these devices basically use an effective refractive index to represent both the anterior and posterior corneal surface. And that would work if the anterior and posterior surfaces remain proportionate, but they don't after laser vision correction. And there's an actual increase in the anterior surface between there's an increase in the radius of the anterior surface and a decrease of the anterior and posterior surfaces. Thus, we cannot use these numbers for calculating the correct corneal lens power. So what happens? Well, with post-refractive myopic laser vision correction, you end up measuring corneal keratometry measurements are actually steeper than the real measurements, leading to a hyperopic overcorrection for the patient. And the opposite is true for hyperopic LASIK, where we're measuring actually flatter corneas than are actually there, and therefore we end up with a myopic overcorrection for those patients. And historically we've used a clinical history method or a hard contact lens method to do this, but these have largely fallen to the side. We know that laser vision correction not only alters corneal configuration and curvature, index of refraction, and power, but as mentioned previously, topography, traditional topography basically does not compensate for this ratio of difference between the anterior and posterior cornea, resulting in a potential to 25% error in the IOL power calculation. We now have tomographers such as Pentacam and Galilee, which can actually measure true net corneal power for more accurate keratometric readings, and most recently we have the use of anterior segment OCT, such as the RT-View, OptiView, which can also measure true corneal power for keratometric measurements. The Pentacam Holiday EKR report has become a very popular device to use. It provides equivalent K readings as shown here in this patient with post-LASIK keratometry. And these, you can look at different optical zones here to measure keratometric measurements. I historically, before some of the formulas became more readily available, used this depending on the level of myopic correction, kind of decreasing the choice of optical zone based on corrections. So for example, a minus 10 correction, I might end up using the average between a 1 and 2 optical zone versus a minus 2 correction, where I might use a 4 millimeter optical zone. Again, probably one of the most newest introductions for measuring corneal power is the use of anterior segment OCT, and the RT-View provides a nice corneal power pachymetric map. It shows net anterior and posterior corneal power displays. And this is the web page from Dr. David Wong which is the COOL webpage, the Center for Ophthalmic Optics and Lasers, and you can download a OCT-based IOL calculator from here, which is quite useful. It's a nice spreadsheet that allows you to enter the data from the RTView spreadsheet and calculate. And this OCT-based IOL calculators have been shown to be quite accurate. If you look here, you can see the OCT actually outperformed the Haggis L and Shamus PL for both being within a half a diopter, that I think 55% that was mentioned by Dr. Manisha, and within a diopter of almost 90%. So this seems to be a very, very powerful way to calculate post-operative, post-refractive IOL calculations for these patients. There's a lot of different formulas out there. I think it's easy to get confused. They're kind of broken down into two different categories: those that predict corneal power based on different multiple factors, and then using that K reading to plug it into a particular formula. The other one uses the current K readings and then plugs in some fudge factor. And then within each category, those are divided into both preoperative history and no history methods. And the Hoffer-Savani was a LASIK tool, was a early one, but was quite complicated once you entered in all the data. And this is not used so frequently anymore. Other more recent additions, which Dr. Manisha mentioned, is the Haggis L, which came out in 2008 and is available on all IOL masters with version 4 or higher, and then a more recent hyperopic version that is available also on the IOL masters and as on the ASCRS calculator. Probably the most popular online post-refractive IOL calculator is that from the ASCRS. This was really developed by Hill, Wang, and Koch. And basically it's free, so you don't have to be a member of ASCRS. You can go to the home page, pick the online tools, pick the IOL calculator, and then this will bring up a nice display where you can choose prior myopic LASIK PRK, prior hyperopic LASIK PRK. And there's version 4.6 has a lot of new additions which have improved the accuracy of these calculations. This is the typical display. For those of you who haven't seen it, it can be broken up into preoperative LASIK data, if that's available, postoperative LASIK data, and then just optical biometric data for the calculations. I usually just use the optical biometry data, which uses no prior data. It provides me with both Shamus and Haggis L calculations. And this has actually been shown in a paper from JSCRS in 2010 that basically methods using no previous data actually gave better results than methods using preoperative LASIK data and surgically induced change in refraction. So if you have access to optical biometry, these tend to give you the best results for the post-LASIK patients. I also just want to mention another thing, which is that most of these measurements, when you're choosing for post, and Dr. Manisha mentioned this, post-myopic refractive surgery, is that most measurements fall. She mentioned, I think, 17 to 23 diopters. I actually use 18 to 22 diopters. If it's outside of that for emmetropia, your measurement is probably wrong in some way, and you need to go back and reevaluate the data that you collected preoperatively. Effective lens position also has been talked about. Basically, more studies suggest that errors in corneal power don't account alone for these residual refractive errors in the post-refractive patients who undergo cataract surgery. And as mentioned, many of the third-generation formulas make assumptions about the effective lens position that really are not valid in the post-refractive patient. So basically, patients that have relatively flat corneas are assumed to have shallower anterior chambers, and that basically will result in underestimations of anterior chamber depth and assume that the effective lens position is more anterior. To combat this issue, you can formulas like the SRKT formula have been adapted to use kind of preoperative K values to determine effective lens position, and then the post-operative K values to do the actual IOL calculation. And this double K method has worked very well in the past, a little more cumbersome than some of the online methods, but again, a very effective way to do that. And if you don't have that preoperative data, you can use the things like the Holiday Consultant software. Basically assumes a default of 44 diopters to computate the effective lens position. Obviously, a discussion about IOL calculations wouldn't be complete in 2015 without talking about intraoperative aberrometry. We now have the Elcon Aura Verify as well as the Clarity Holos Intraop. And basically these devices attach to the operative microscope and use wavefront technology. And in the case of the Aura is the Talbot-Marie interferometry, and basically take intraoperative aphakic measurements to help the surgeon select the particular IOL power, potentially eliminating the need for biometry and keratometry for the IOL power. And also mentioned during one of the other talks is the use of light adjustable lenses, which is only in phase 3 in the US, but hopefully will be approved soon, which will allow us to do adjustments post-refractive surgery to optimize visual outcomes for the patients. So in summary, surgeons have the following options for post-refractive patients. One is to use multiple formulas to determine corneal and power. These are obviously available with various spreadsheets, software in the IOL, in the optical biometry machines, as well as the different websites. Determining the true corneal power either using tomography such as Pentacam or Galilee, or most recently anterior segment OCT, such as the OptiView True Corneal Power Map. This has actually been shown to have better spatial resolution compared to tomography of 5 microns versus 15 microns. And lastly, using intraoperative aberrometry, which obviously has probably the most limited access, such as the Elcon Aura Verify or Clarity Holos Intraop. So patients requiring laser vision correction really alter the way we have to determine laser vision corrections, particularly the keratometric readings. We should use multiple methods to determine the correct IOL. You can use the Haggis-L and the IOL Master, the online ASCRS IOL calculator, or the anterior segment OCT with the IOL calculator. Probably what's most important in this, or equally as important, is that you have a good discussion with your patient and let them know about the expectations and the difficulty in calculating the IOL power. Obviously, patients who have had previous refractive surgery will potentially want premium IOLs and really do want premium results. So I think having that discussion is important, since we have a much larger chance of being off from our expected target. So although we're getting it almost right, we're not quite there yet. I think there's no perfect solutions, but you should definitely ask colleagues for help if you're not familiar with doing these calculations frequently. Thank you very much.
Thank you, Dr. Pineda.
Thank you.